Good evening and welcome to session 1 of our virtual patient education series, 2020 New and Emerging Treatments for Blood Cancers. Thank you so much for joining us this evening. My name is Carrie Callis and I am the Director of Programs at the Leukemia Research Foundation. We're pleased to present this event in partnership with the Cardinal Bernardine Cancer Center at Loyola. We typically have this event in person, but because of obvious reasons, we moved to a virtual format and we really appreciate you adjusting to this virtual setting. We would like to thank our supporters this evening, AbbVie, Jazz Pharmaceuticals, Karyopharm Therapeutics, and Novartis Oncology. As a brief background about the Leukemia Research Foundation, the Foundation's mission is to conquer all blood cancers by funding research into their causes and cures and enriching the quality of life of those touched by these diseases. Since its inception in 1946, the Foundation has funded over $80 million of research grants to over 500 new investigators on 5 continents and supports patients and families living with a blood cancer diagnosis through educational and support programs. I encourage you to visit allbloodcancers.org to learn more about our patient support programs and resources, including our online support community and our comprehensive listing of resources. At this time, I would like to introduce our moderator of tonight's program, Dr. Patrick Stiff from Cardinal Bernardine Cancer Center at Loyola. Dr. Stiff is the chair of the Foundation's Medical Advisory Board, and we thank him for all he does to advise and support our work at the Foundation, as well as for moderating this program tonight. So I'll turn it over to you, Dr. Stiff.
So thank you all for participating. This is going to be saved and archived for future use, and you can review it back on the screens on your home computers or wherever you want to look at these talks and refresh your memories, etc. in the future. We have 2 presentations tonight. In 2 weeks, we're going to have another 2, and then 2 weeks after that, another 2 presentations. And these are going to cover the gamuts of blood cancers. We are pairing these up a little bit, and tonight we're going to have 2 speakers talk to us about terminally differentiated lymphoid cancers. First, chronic lymphocytic leukemia, and then second, multiple myeloma. Actually, there's a lot of similarities between the 2 of them, both fundamentally and treatment-wise. But you'll have an opportunity to answer questions. We got a bunch of questions already, which I will go over at the end for our 2 speakers. These are very good questions, and it does show me something that I've known for many years, a high level of sophistication for patients that participate in these seminars. So without a lot of to do beyond that, I'm going to introduce Dr. Venugopal, who's chair of the Division of Hematology at Rush University Medical Center here in Chicago. He's been a long-time friend and a friend of the Leukemia Research Foundation. He's a well-respected blood cancer specialist and in all areas, but he focuses mostly on lymphomas and chronic leukemias. And he's going to speak first on updates in chronic lymphocytic leukemia and small lymphocytic leukemia. And then when he's done, we'll move into our second presentation. There will be no opportunity for questions until at the end. So Carrie, you're back on, and I'll mute myself, and then everybody welcome Dr. Venugopal.
Great. Just there we go. We can see you, Dr. V.
Can you hear me?
Yes, let me have you share your content. I'm just trying to move the presentation over to you. Just one moment.
Good evening. Nice to see you.
Nice to see you. Can you all hear me?
Yes, we can.
Wonderful. Thank you, Dr. Stiff and the Leukemia Research Foundation for giving me this opportunity once again. It is one of the best things every year. Participating in a meeting like this with Dr. Stiff just told you has been organizing, and so far we have been doing it in a large hall and had the opportunity to meet and talk to all of you in person, but unfortunately this time it is through this video, and we will work it out. Okay, I'm going to share it, Carrie. Can you see my presentation?
Yes, we can.
Wonderful. Okay, so over the next 20 minutes, I'll be talking to you about two diseases, chronic lymphocytic leukemia, CLL, and small lymphocytic lymphoma, or SLL. Just like Dr. Stiff just told you about the similarities between, two of the diseases that are being presented today, the CLL and myeloma. These two diseases I am going to talk about are very similar. In fact, in many of your blood report and pathology report, you will see SLL/CLL. And these diseases are very similar. They look very similar under the microscope. The cells have very similar characteristics where it is expression of proteins or chromosome abnormalities. And also in terms of treatment, it is very similar. So I'm going to focus my discussion primarily on chronic lymphocytic leukemia, and of course we'll emphasize wherever something needs to be emphasized on SLL, and of course I'll be able to answer the question at the end if you have any specific SLL questions that were not addressed. So the first few slides I will talk about what we have learned in the past few years that is new, which helps us determine the prognosis and identify appropriate new treatment options. CLL, as you know, is the commonest type of leukemia above the age of 19 years. That's the commonest leukemia. It's a disease that is common in older individuals. And most of the time when it is diagnosed, the patient doesn't have any symptoms. And prognosis can be determined based on many things, including one of the very early staging system, RISE staging based on blood counts, enlarged lymph nodes, spleen, anemia, and low platelets. And if you look at the graph on the right side, it shows that in patients who are below 75 years old, all those groups, the survival is impacted by the disease. Now, this gives you an idea of how many new cases will be diagnosed in 2020 in the United States. So, an estimated number of new cases, about 21,000 plus. The good news is that majority of these patients live long. As you can see, 5 years, more than 86% of these patients are alive. The graph here, the green one represents the incidence of CLL. As you can see, in the last 10 years, the incidence has been coming down. The number of new cases has been decreasing. And this is the graph showing the death rate. That also you can see over the last several years and decades, the death rate has been declining slowly but steadily, largely because of our better understanding of the disease and better treatment options. How is the disease diagnosed? In simple terms, you go to a primary physician for a routine checkup, which is a very common situation, and the physician finds that your white cell count is slightly elevated, and he or she will say, come back after 1 month. You come back after 1 month, check again, the white cell count is still elevated. At that time, the physician may refer you to a blood specialist or a hematologist. The hematologist looks at your blood smear and sees these cells. These are the lymphocytes you see under the microscope. Then he does a variety of tests in the blood, which will tell the features of these. And the tests that are done are blood counts, of course, blood smear, which is what I just showed you, and a test called flow cytometry, which can tell fairly accurately the diagnosis of CLL in most cases. So the point is, for diagnosis and confirming the diagnosis of CLL, blood test is all that is needed. You don't need a bone marrow biopsy or CT scan or any other scans. What is my prognosis? That's a very common question that is asked once you have a diagnosis given to you. This will depend on a variety of factors, but some of the newer factors you should know when you talk to the doctor are listed here. CD38, ZAP70, these are proteins expressed on the leukemia cells. If they are high, they have a less favorable outcome. Similarly, you should know the status of the mutation of this is called IGHV mutation. This protein in the blood is an important one. The chromosomes and FISH analysis is routine, and you should know about your chromosome abnormalities, especially knowledge of these high-risk abnormalities is very important. And of course, gene mutation. So these are terms you should be asking your doctor, what is my chromosome study showing? What is my FISH showing? Is there any high-risk chromosome abnormalities, PCR, mutation analysis, and NGS is next generation sequencing. This is a study of the gene pattern of the leukemia cell. So these are some terms you should know when you talk to your doctor. Just to show you an example, if you look at the FISH results, if you have a 17p chromosome abnormality, these patients disease progress very quickly. These are the patients who are surviving, and this is a time. You can see that this line goes down very quickly. That means the patient's disease progress very quickly if they have this abnormality. Compared to patients who have normal chromosomes, you can see that their disease progress very slowly. So it's very important to know chromosome abnormalities. What are the indications of treatment, starting treatment? Because most patients, when they are diagnosed with CLL, they don't need treatment, but the doctor will be watching you each time they see you to see if you develop any indications. Some of the indications are listed here, like if you develop symptoms, fever, night sweats, weight loss, or if you develop evidence that your bone marrow is failing because the CLL cells are packing the bone marrow, like anemia or low blood counts, like low platelets, or if your spleen or lymph nodes are getting very big, causing symptoms, these are all indications of treatment. Now, one of the questions I received from one of you before the talk was, in this day and age when we have new drugs, should we still stick to these? The answer is yes. The point is, observation is appropriate in the absence of indication for treatment. So having said that, what are the appropriate options for treatment? First, we will look at the options of treatment for first line. Chemotherapy has been used for years. We still use it, but its use is very limited now because we have all these newer agents which have much less side effects than chemotherapy. Monoclonal antibodies are proteins like rituximab, which is known to most of you, but there are newer monoclonal antibodies which I talk about. You can combine these two and make combinations like FCR, BR. These are chemotherapy combinations we have used for a very long time. And of course, the new drugs we'll be talking about. Always remember, clinical trials are the best way to have an opportunity to get newer combinations of medications and newer medications. Always you should ask your doctor about clinical trials that are available. If you look at the new drugs that has come up in CLL treatment in the last 10 years, you have a variety of names here: Ibrutinib, Acalabrutinib, Ofatumumab, Obinutuzumab, Idelalisib, Duvelisib, Venetoclax. I'm going to talk about these in the next slide, so I'm not going to spend much time on this slide. So the first group I will talk about is the so-called monoclonal antibodies. You can see here, this is a leukemia cell, and these are the proteins that are expressed on the cell, on the surface of the cell. CD20 is a target for rituximab. Like rituximab, you have ofatumumab and obinutuzumab. These are newer rituximab-like drugs which are FDA approved. There's also a clinical trial drug which is not yet approved. The other group is so-called PI3 kinase inhibitors. These two drugs, duvelisib and idelalisib, they are oral drugs which are very effective. You have the so-called BTK pathway inhibitors, Ibrutinib, acalabrutinib, and the more recently approved zanubrutinib. Venetoclax is the inhibitor of the protein called BCL2, a very effective way of controlling the cells, the leukemia cells, and I will talk about that. And there are certain other areas which are being investigated, including CAR T cell, which I'm pretty sure you will be hearing more in the myeloma session. Let's look at the BTK inhibitors. This slide shows you the 3 BTK inhibitor drugs that are in the market. One is Ibrutinib, which was the first one to be approved, acalabrutinib, and the more recently approved zanubrutinib. Zanubrutinib is FDA approved for a lymphoma called mantle cell lymphoma. It's not approved for CLL yet, whereas these two are approved for CLL. Now, this is given once a day. Acalabrutinib is given twice a day, and this drug is given once a day or twice a day. There are some side effects associated with ibrutinib, including irregularities of the heart, as well as bleeding, especially if you take it with blood thinners. Headache can occur in about a third of the patients who take this drug. And side effect appears to be less with this one, but we don't have any straight head-to-head study in CLL in these with these drugs. For example, if you take ibrutinib alone without any other medication, you can see that the PFS, or progression-free survival, which means the time when your disease remains under control, is excellent. At 7 years, 83% of the patients have disease very well under control by taking this oral agent alone. And at 7 years, 84% of the patients are alive. This is overall survival. So very efficient. No question about that compared to what we were using before. Let's compare it to a chemotherapy pill we have been using before, chlorambucil. Ibrutinib works much better. This is again the progression-free survival, time it takes for the disease to progress when you are taking this drug. In the last year, the 2019, there were 3 trials, big trials, which influenced our treatment opportunities and treatment decisions in 2020. So I'll briefly talk about them. One is combination of obinutuzumab or Gazyva with ibrutinib or Imbruvica, showing that patients who receive that combination have much better outcome compared to patients who take the antibody and the older pill, which is chlorambucil. Even in patients who have high-risk disease like high-risk chromosome abnormality, this works very well. So this is the first non-chemotherapy combination that was approved by FDA, and that was in January of 2019. And here is a comparison of ibrutinib and rituximab with one of the most effective chemotherapy regimen we used in the past called FCR. What does it show? Ibrutinib combination with rituximab works much better in keeping the disease under control, and these patients live longer compared to patients who get chemotherapy. So clearly showing that the combination of this new drug leads to better control of the disease and patients live longer compared to standard chemotherapy. This one is again to show that the combination of bendamustine and rituximab, which is another chemotherapy we have been using extensively, compared to ibrutinib. As you can see here, ibrutinib or ibrutinib with rituximab works much better than chemotherapy BR, again showing the efficacy of novel agents. So ibrutinib and rituximab leads to better disease control compared to bendamustine and rituximab. This study did not show any overall survival benefit, but the disease control was much better. How about patients who came back with disease or relapsed CLL? chemotherapy, antibody, and combination are still options. Ibrutinib, acalabrutinib, and venetoclax are also options for these patients. Again, clinical trials should be looked into. Also, stem cell transplantation. As you know, stem transplantation is a very effective treatment. In CLL, is not very often used because of many reasons, including the fact that many patients are older and have other diseases which may compromise their ability to go through an intensive treatment, whereas this treatment is still very effective and useful in younger, healthier patients who have high-risk disease, where even with the novel agents, their disease may not remain under control for a very long time. So this one shows comparison of ibrutinib with ofatumumab, a monoclonal antibody, clearly showing the efficacy is much better. And this one shows the efficacy of the second drug, acalabrutinib, compared to chemotherapy, does much better. Now, there are trials going on head-to-head comparing these two to see whether they are equally effective or side effects, are they equal, or is there a difference in terms of side effect? Now, we don't have this data. Similarly, there are studies comparing ibrutinib with the third drug, that is zanubrutinib. Again, this is ongoing. We will be looking forward to the results to see if there is a utility in recommending one of these over the other. So summary of BTK inhibitor, as I showed you, ibrutinib as well as acalabrutinib works much better than what is conventionally available with chemotherapy. So let's talk about venetoclax, which is the BCL2 inhibitor. Venetoclax is an oral agent. Again, majority of patients respond to the treatment. Even patients who have this high-risk chromosome abnormality, majority of them respond to the drug. And this is a study where they showed that venetoclax, when combined with rituximab, works much better than the standard combination bendamustine rituximab. So venetoclax plus rituximab leads to better disease control compared to BR. Similarly, venetoclax combined with the newer rituximab, obinutuzumab or Gazyva, does the same thing. It works much better than the standard chemotherapy rituximab or obinutuzumab combination. And this combination of Gazyva and venetoclax or venetoclax was FDA approved in May of last year. So with that, I'm going to conclude my talk with these statements. In the first few slides, I showed you that there has been a lot of developments in the understanding of the disease as well as prognostic factors, which are not only helping in telling the patient about their prognosis much more accurately, but also helping them in making the right choice for treatment. Treatment of CLL and SLL is more personalized now, depending on the characteristics of the disease. And we have now non-chemotherapy options, which have much more efficacy and much less side effects. And as always, I encourage you all to participate in clinical trial, because that's the way people have developed these combinations, and that's the way we can look forward to newer medications and newer combinations. With that, I'm going to conclude, and I thank you very much for your attention.
Thank you very much, Dr. Venugopal, for an excellent summary. And we do have some questions that we'll get to at the end. There is a thing on the corner on the bottom of your screen called chat, and you can type a question in there that we will be monitoring as we go through these presentations and add it to the list. If you've pre-submitted a question, you do not need to put it back again. We have it already, and we'll be addressing those. So again, thank you, Dr. Venugopal, and he'll be staying live, so to speak, for us to answer some of these questions at the end. Next, I'd like to introduce Dr. Patrick Hagen, who's going to talk about the other terminally differentiated B-cell malignancy called multiple myeloma, another very common yet difficult to treat at times blood cancer. Dr. Hagen is Assistant Professor of Medicine in the Division of Hematology Oncology at my institution, Loyola, and he's a member of the bone marrow transplant program. He's in the process of developing 2 new national trials that are going to test some new treatments in multiple myeloma in the NCI-sponsored cooperative group system. And you'll hopefully be hearing about these over the next 6 months or a year. Finally, before he gets started, I would like to remind everybody there's a button right in the middle of your bottom of the screen that says mute, and you should click on that, and there should be a line through the microphone because we are getting a little bit of feedback. So everybody, please mute your microphones, and welcome to Dr. Patrick Hagen.
Okay, everybody can hear me?
Yes, we can hear you.
Perfect. Okay, thank you, Dr. Stiff, for the introduction, and thank you to the Leukemia Research Foundation for having me. It's always a pleasure to come and give these talks, and like the others have mentioned, it's great to be together, but this does give us a unique opportunity to expand our reach and have more people involved. So it's always a pleasure, and I always feel pretty lucky to be in such good company. So I'm going to talk about multiple myeloma and kind of get going pretty quickly, because for good for patients, but for bad for a 20-minute presentation, a lot is happening in myeloma that's really improving patient care. So this is kind of what I'm going to go over. I'll just touch a little bit about how we risk stratify myeloma, because that does dictate what we might expect our patients to achieve with therapy. Then we're going to talk about current landscape in the initial therapy for newly diagnosed patients, move into a myriad of new drugs that have been approved or in the process of being approved in the relapse setting, and then kind of just briefly touch on overall improved outcomes. I think it's important to know where we started to kind of really realize where we've come. We've known about this disease for almost 200 years. This is from a journal with the first reported case of myeloma in the medical literature, a young woman named Sarah Newberry, who would pass away about 4 years after the onset of her symptoms. At that time, these were the treatments for multiple myeloma, and these really didn't change much for about the next 100 years. Things like orange peel, Dover powder, rhubarb pills, and actually leeches were used as the first quote-unquote maintenance therapy. So as you'll see, we've come a long way. When you're talking about myeloma with your doctor after diagnosis, one really important thing to understand is what is your risk. And unlike other cancers, staging or risk stratifying myeloma is different. This is a cancer that comes from the bone marrow, the plasma cells. These are cells that make good antibodies, which is depicted up here on the top right. And over time, as they divide, mutations and mistakes happen in the DNA, which make them become cancerous. And it's those mutations particularly that dictate how our patients might do. And you heard that in the last presentation. It's the FISH, or the cytogenetic, the genetic mutations in the cancer cell. And so not all myeloma patients are created equal. This is on the right, you'll see a table with our old staging system, something called the ISS, and then our new staging system down here on the bottom right, something called the revised ISS staging system. Unlike CLL, we generally do need a bone marrow biopsy to diagnose myeloma, and that, in addition to blood tests, allows us to tell you how we might expect you to do with therapy. There are some known high-risk features, so these FISH changes, these are listed down here, cytogenetic FISH changes. So things like a 17p deletion that you just heard about in CLL also is high risk in myeloma. And then we look at other things, other blood tests like your LDH or your beta-2 microglobulin. And with this information, we're able to tell you your stage. And as you can see, although myeloma patients are doing great, those with high-risk features, unfortunately, still are not living as long of a life as we'd like to see. So more work to be done. It's important, too, because this staging system is applicable to patients who are undergoing transplant in their initial therapy or not, those who are treated with a certain class of drugs called IMiDs, and I'll talk a little bit more of that, or proteasome inhibitors. So overall, no matter which way your therapy goes, this staging system impacts outcomes. So let's move into therapy. So we're going to start with kind of our older therapies used in the initial treatment. The initial therapies in myeloma were largely steroids and what we call alkylating agents. These are chemotherapy drugs. They make the cancer DNA unstable. The early drugs were melphalan and cyclophosphamide. Some later drugs were introduced, such as busulfan. And melphalan remains actually the backbone of stem cell transplant, and it can still be used in the relapse setting often. There's a new kid on the block I'll talk about in the end called melflufen, which is a new type of alkylator. Next, we have proteasome inhibitors. So unlike alkylators, these are more specific to myeloma cells. Alkylators are basically chemotherapy. Proteasome inhibitors really target more in on the actual myeloma cancer cell. They cause basically a part of the cell to become unstable, which causes the cell then to die. The first drug that we had in general use was a drug called bortezomib or Velcade. This is part of the RVD, kind of your standard induction. Later generations were developed, such as carfilzomib, ixazomib, and then there's a couple more that are in clinical development right now listed here on the bottom, Marizabib and aprozomib. The next big class of drugs we have in myeloma are called immunomodulators. So the best well-known one in myeloma is a drug called Revlimid, listed down here under later generations. The early drug, and this data is wrong, so excuse me, was a drug called Lenalidomide, which is not used as much in the United States, more so in Europe and around the world. These drugs are very good. They engage the immune system to attack the myeloma. They do a number of other things in the way they work, and unlike alkylators, again, they're more specific, so they're better tolerated. The kind of newest kids on the block, they're getting old now, are monoclonal antibodies. So these are basically antibodies that we generate that target the cancer cell. So again, unlike chemotherapy, these are more targeted. They have less side effects. The early drug that was developed was elotuzumab, which was improved in 2015, and subsequent daratumumab, and then most recently, just this year, isatuximab. Daratumumab now has really changed the landscape of myeloma therapy. So those are our drugs. So as of 2020, I think there's some important tenets to understand. Multiple myeloma is a chronic disease. It's not a disease we can cure. So in my opinion, there are really three goals. We want to get you into remission. We want to keep you in a remission for as long as possible. And we want to do so with the least impact on your quality of life. So how do we do that? It's a three-step process. We induce or we use a combination of drugs to get the myeloma into remission. Then we consolidate or we try to deepen that remission, and that's typically done with high-dose melphalan and transplant. And then we need to keep you on maintenance to maintain that remission for as long as possible. Because again, as of today, the vast majority of myeloma patients, this is a chronic disease. And we would highly encourage every patient to participate in clinical trials. This is your best chance at an improved outcome, and it's the way we move the field forward. So at every step of the way, you should be asking your doctor, is there an opportunity to be involved in a clinical trial? So in terms of the induction or the first step, really it's a three-drug regimen, a combination of three drugs that's used. The backbone is always a steroid, dexamethasone, and in almost all cases, a drug called lenalidomide or Revlimid. This is one of the IMiDs I mentioned earlier. Then the question is, what should be the third drug? And there's been a lot of recent data that I'll go over briefly here. So a question you might be asking your doctor is, well, if I'm going to get Revlimid and dexamethasone, what might be the best third drug for me? Well, we thought we knew, so we did a big trial recently called the Endurance trial, which compared KRD, so that's carfilzomib with Revlimid and dexamethasone, one of the proteasome inhibitors, with a combination called RVD or VRD, so that's Velcade, one of the other proteasome inhibitors. And as you'll see, this top is the progression, this bottom is the survival, and there was no difference. So there were differences in toxicities, but again, as long as you're getting a three-drug regimen, you're on the right path, and then you need to look and talk with your doctor about what that best third drug might be. This was just published this year. There was another recent publication in the last year, a trial called the Maya trial, and this looked at adding daratumumab as your third drug. So that's one of the new kids on the block, one of those monoclonal antibodies, very well tolerated. And this was daratumumab, this graph you're seeing above, and we added it to our just Revlimid and dexamethasone, and we've seen very good outcomes. So the median progression-free survival and time to progression wasn't reached, and at 30 months, almost 3/4 of patients on the daratumumab had not progressed. So what's the answer? The third drug really depends on a couple of things. Daratumumab is not approved as initial therapy in patients with the intent to head to transplant. That's a big question. Next question is, what are the potential toxicities? So carfilzomib has issues with the heart and raise blood pressure. So if you have those problems, that drug might not be right for you. If you have diabetes and you have neuropathy, the Velcade or the bortezomib might not be the right drug. And in general, we do need to consider the ability to tolerate three drugs. Some of our patients who are older and more frail can't do it. And doublets in those cases, there are 2 drugs are okay. Sometimes we'll use something called RVD light, seen at the bottom here. That's just basically a dose reduction of our standard triplet. And there are clinical trials now that are being designed to look at this. So the next question you might be asking in your initial therapy is, in today's world, with all these new drugs, do I still need a transplant? Well, I'm a hammer and transplant is a nail, so my answer to that is yes, but the data would back me up. So these are 4 trials that have been done and recently published. All of these trials compared upfront versus delaying high-dose chemotherapy and transplant as consolidation. And every single trial shows about a 1.5 year progression-free survival advantage, and some of the trials show an overall survival advantage. And ironically, just today, there was a paper published by the EBMT, or the European Bone Marrow Transplant Group, and they looked at all the data, and everybody is still recommending this. So the answer is yes. Every patient should at least be evaluated for the role of high-dose melphalan in autologous stem cell transplantation. Not everybody will be a candidate, but it should be offered to all patients. And we need to stop doing the studies, but that's just my opinion. So doctor, this is another question I get. If I'm in a deep remission after transplant, do I need to continue therapy? Again, the answer to that we'll get to here. So myeloma is a chronic disease. We have to engage the immune system in surveillance to keep the disease from relapsing. So this is the role of quote-unquote maintenance after your transplant. And we're seeing that when we do maintenance, we're seeing improved times of progression by, again, at least 1.5 years and probably longer. And in a recent meta-analysis where we looked at all these big studies that looked at maintenance, there was an improved survival. So this is depicted here on the top. So the blue is patients who get maintenance. The yellow is the patients who don't. So there's a big difference in progression. And down here is survival. So what are the next steps? We do need to do some risk-adapted maintenance approaches, and these clinical trials are ongoing. So the answer is, do you need maintenance even if you're in deep remission? I would say the answer to that is definitely yes if you want to stay in remission. And it's very likely that this will improve your survival. And that's being studied by studies such as the MASTER trial, which is looking at patients who are able to get into really deep remissions for a long time. Can they potentially stop? And then we have a big trial in SWOG that's looking at modifying the maintenance based on how patients are responding over time. These are important questions that are being asked. A few notes on supportive care. So this is critically important in myeloma. It's a disease of the immune system. So there's lots of bone problems. So you should talk to your doctor about calcium and vitamin D. You should be on some medications to strengthen your bones, typically for at least 2 years once you're diagnosed. So something else to be aware of in talking to your doctor. There's a high risk of blood clots, so most patients need to be on aspirin or some sort of a blood thinner to prevent this. Infections are a big problem, so being on preventative anti-infectious agents is important. And finally, critically important is vaccination, so against things like shingles and pneumonia. So these are all things you should be talking to your doctor about, and they should be managing with you. So that's upfront therapy for myeloma in less than 10 minutes. Now let's try to cover relapse therapy in myeloma, where the landscape is really changing quickly. Again, just like up front, I would encourage all patients to participate in clinical trials. At least discuss it with your doctor. It's not right for everybody, but it should be discussed, and there are lots of opportunities. Many of the same principles apply when the disease comes back. So right now we're getting on average 4 to 5 years up with our initial therapy, but eventually it comes back. And when it comes back, 3 drugs are still better than 2. We treat until progressive disease, and there's an ongoing importance of all that supportive care I just mentioned. There is really a lack of head-to-head clinical trials in the relapse setting to compare regimens, but we'll talk a little bit about what we know. So again, it's what drugs are right for you, what medical problems do you have, and what previous therapies have you had. So there really isn't one best treatment approach for any given patient. And treatment is, like I said, tailored to your comorbidities and your ability to tolerate therapy. And again, just like up front, when you're initially diagnosed, when you relapse, you should talk to your doctor about risk. You should be asking questions like, are there any new high-risk changes in my bone marrow? How long did you go from your initial therapy to your relapse? These are really what dictates long-term outcomes. So triplet regimen, our 3 drugs, are extremely effective in relapse disease. So these are just 2 studies where we looked at adding carfilzomib, again, a proteasome inhibitor, to Revlimid and dexamethasone, and we saw 26 months of time before the myeloma comes back. And then in a recent study just published this year in The Lancet, we did a study where we add that drug daratumumab to carfilzomib and dexamethasone. And again, the median time to progression wasn't even reached. So these are just very good active 3-drug regimens, good options for all of our patients when the disease relapses. Although we don't know which regimen is best, there have been some attempts to look at this. And so on the left, you're seeing all these different 3-drug regimens, some 2-drug regimens. And as this bar goes to the left here, on the right side, so what you'll see up here on the top, this daratumumab, lenalidomide, and dexamethasone triplet is being shown to be the best. But at the end of the day, these are not randomized trials. These just shows that there's a lot of good regimens, a lot of good treatment options out there for you. Another important thing to consider when the disease comes back, consider strongly, is a second transplant. Patients who go at least 18 months without maintenance, and definitely 36 months with maintenance, have really benefited from their initial transplant. And there's data that would say if they get a second transplant after a long remission, there's probably a survival advantage. This is why we collect enough for 2 transplants up front, and this is something we're actively trying to study actually right now in SWAT. So to finish up, what about the new kids on the block? There's been a lot of action recently in myeloma, a lot of new drugs. Let's go through them, at least overview, and we can talk more in the questions. So melflufen, this is an alkylator just like those original chemotherapy drugs, but it works a little different. Here in this slide, what it's showing is melflufen is actually bound to a carrier. It enters the cancer cell, and cancer cells have more of these peptidases that cleave the carrier. The melflufen then gets stuck inside the cell and does a better job of killing it. So it allows us to basically give less of the drug and have it be just as effective. So this is a really exciting new drug. There's been a bunch of studies. The Horizon study was a phase 2 study. The Ocean study was a phase 3. And right now this drug is under priority review from the FDA and likely to be approved soon. The next new class of drugs are called antibody drug conjugates. So these are basically like a loaded gun. We take an antibody that can find the myeloma cell and we put a toxin on it and it finds the cell and kills it. Belantamab, which was just approved, is the most well known. But right here you'll see these are all drugs that are in development that work this way. So we'll talk about belantamab on the next slide, but there's a lot upcoming. Belantamab basically, again, is an antibody that binds something called BCMA on the cancer cell, which is shown over here on the right. And attached to it is this toxin. So it binds, the toxin goes into the cell and kills it. It also engages the immune system as well. Belantamab has shown really promising phase 1 and phase 2 data, and now is approved. It had a response rate of 30%, and those who responded for 11 months. So this drug is looking good. It has unique ocular toxicity of the eye, so that's something you need to be aware of. Next is a class of drugs called nuclear export inhibitors. The approved drug is a drug called selinexor. These drugs work by there's basically a receptor that gets rid of these proteins called tumor suppressors that prevent the cancer cell from dying. So the drug blocks these receptors, and then the cell is able to do its normal dying process as the body recognizes that it's a cancer. The STORM trials is what's got this drug approved. It had a response rate of about 20%, the duration of response about 4 months. The Boston data is a study that's well known, combining it with a drug called Velcade or bortezomib that we mentioned earlier. And right now there is basically a large group of trials where they're combining this drug with a lot of other drugs. It is toxic. It has a lot of toxicity. It can be tough to take, but when dosed right and in the right patient, it is a good drug. So the next group of drugs are the multi and bispecific engagers. The one that I'm going to talk about is a drug called AMG 701, but there's a number of these. Just like with those antibody drug conjugates, here's about 10 drugs that are in clinical trials that are looking promising. So a lot more to come here. How do these drugs work? So basically we take an antibody that combines the myeloma, combine the tumor cell, and combines your immune system and engage it. So the tumor cell is brought to your immune system, which proliferates and then kills it off. There are a variety of phase 1 and 2 studies underway, and there's a lot more to come. And then finally, kind of the hottest topic in myeloma therapy is CAR-Ts. So what are CAR-Ts? Essentially, these are your own lymphocytes or white cells that are taken out of your body and then are engineered to fight the cancer. They recognize a receptor on the cell, something called BCMA that I mentioned already several times. And after the cells are taken out of your body, they're engineered to then attach to that receptor, that BCMA receptor, grow and kill off the cancer. So this has been used heavily in lymphoma and then in ALL, and as we just heard, it's being explored in other cancers such as CLL. The myeloma, the data has looked really good. So this drug, BB2121, was published in the New England Journal, a phase 1 study. These were heavily pretreated patients, a median of 7 lines. There are some unique toxicities that you need to talk to your doctor about. This isn't right for everybody. But we saw unprecedented responses, a CR rate of 45% in patients who had 7 lines of therapy, and PFSs of approaching a year in those who are responding. Patients are relapsing though, so this probably still isn't curative. There are many ongoing studies that I'm not going to go into here, but this just shows the landscape. It's ever expanding, and I created this slide a few weeks ago, and it's probably changed since then. 2 drugs are likely to be approved in this coming up 2021 year. So more to come. This will be part of the landscape. And then finally, a bunch of drugs that I'm not going to go into any detail in lieu of time are being developed, some of which you heard in the last talk, Venugopal and Ibrutinib, and many others that look promising. And I'll leave you with this slide. So this is a really important slide to see. So this is basically cancer registry data, and it shows that patients of any age group less than 65, 65 to 74, or greater than 75, and in all racial groups, whites, Hispanics, and blacks, survival over time is going up. So for those less than 65, it's gone from 38 to 61% in 5 years. For those in 65 to 74 years old, it's gone from 29 to 48%. And even in our most elder patients, it's improving. So with that, hopefully I didn't cover too much too quickly, but it's a really changing landscape very quickly, and there's a lot of exciting things that I didn't cover and many more things to come.
Thank you, Patrick. And again, these slides will be available as well as the actual presentations on the Leukemia Research Foundation website. You can go back and play them over and over again. And if there's something that you don't understand, there'll be an opportunity to send questions in, and we'll be able to potentially later on answer the questions.
Everybody still there?
We are. Me? I hope you can hear me.
Yes, we can hear both of you.
Okay,
if you want to show your video for the Q&A, that might be helpful.
All right, there you go. We're back. All right, so I just clicked it twice. So what I'm going to do is Dr. Venu back on.
I can hear you.
Okay. Can you hear me?
Okay, great. So what I'm going to do is I have a bunch of questions here, and what I'm going to do is I'm going to go back and forth to the both of you, and you can feel free to comment as well on the other person's questions. So the first one is for Dr. Venugopal. Once treatment starts for CLL, is it possible to stop once the white cell numbers decrease back to normal?
Very good question. So can you hear me first of all?
Yes.
You can. Okay. So there was a list of questions before the talk I was given, and there are 3 participants who asked the same question. So I think it's an important question because many of the new agents like Imbruvica or Acalabrutinib I showed, including Venetoclax, originally was approved for single agent to be used as long as the disease remains under control and as long as you don't develop any unacceptable side effect. But the question is, can we shorten it? Can we have a fixed duration treatment rather than taking it forever? You know, not only it is inconvenient, but also it's a costly thing. So yeah, the answer is yes. For example, Venetoclax is now approved in combination with Gazyva or obinutuzumab. You take it the IV, that the Gazyva, you take it for 6 months, and then you continue taking the Venetoclax for a year. And when you stop it, 1 year after stopping, 88%, almost 90% of patients still don't have evidence of disease. So we need long-term data follow-up, which will tell us that if it is safe to do that. But at this point, it looks like we should be able to stop treatment after some time, especially if we can demonstrate that you have achieved a level of remission called MRD, or minimal residual disease.
Great, thank you. And a similar type of question for Patrick. How is one maintenance schedule determined for multiple myeloma? For example, is it every 2 weeks, monthly? And how long do you give maintenance therapy in patients with multiple myeloma?
Yeah, that's a good question. So typically the maintenance has been studied in 2 traditional dosing schedules. One is given every 3 weeks on and 1 week off. Can you hear me?
Yes.
Okay. One is given every 3 weeks on and then 1 week off, or it can be given continuously. And some of our newer trials are actually giving it continuously. Depending on how you're tolerating the maintenance, that can be adjusted, but traditionally that's how it's dosed. And in terms of how long, the answer to that is pretty simple. The standard of care, in my opinion, is the maintenance is continued until the disease progresses. Now, just like we just talked about in CLL, there are studies ongoing now to look at things like sustained MRD or minimal residual disease negativity to see if we can stop it. But every time we've studied it so far, when we stop the maintenance, the risk of progression or relapse goes up.
All right, next, another CLL question. And again, these have applicability potentially to both diseases. When will CAR T be a first-line option for CLL? And how are doctors choosing which patients to recommend for CAR T for CLL? In a battle of second-generation BTK inhibitors and CAR T, who wins?
Wonderful question. If we knew the answer, we would have been probably in a different place. So I think to answer the first question, CAR T is a treatment now FDA approved for lymphoma, leukemia, and more recently, of course, another type of lymphoma. But the first time CAR T was shown to work was in CLL. That was quite some time back, but still, we are still far away from getting CAR T as a treatment option for CLL. One of the reasons may be because of the availability of many other effective treatments. So the CAR T has not been developed like the other diseases. My impression is that the next CAR T that will be approved is most likely for multiple myeloma. Maybe Dr. Hagen or Dr. Stiff can comment on that.
Okay, so I can ask Dr. Hagen the same question. When are we likely to see CAR Ts for early treatment in multiple myeloma? And how would you go about testing this, or what are the plans for doing those types of trials?
Yeah, there are some. So I would say we're likely to see CAR T therapy approved in relapsed myeloma in late 2021. So it's on the cusp. It is being studied in the upfront setting, particularly in patients who are younger and very high risk. Because unfortunately, although we made a lot of headway in myeloma, in our highest risk patients, it's really lagged behind. So I don't see it as being the standard of care by any means, an upfront setting for potentially many years to come, and maybe not ever. But it's certainly going to move its way into the relapse setting when the disease comes back, and I think it will inch closer and closer over time in terms of patients will be getting it earlier in their disease course.
So again, now another question on multiple myeloma. We treat cancers, Hodgkin's and leukemias, et cetera, with more than one cycle of chemotherapy. And when we give patients induction therapy, we give them 3 or 4 cycles. But pretty much we only do one transplant. There's been a lot of work over the many years on doing 2 transplants or tandem transplants. What's the latest update on the use of tandem transplants in myeloma?
Yeah, the update is it's a conflicting story. So every time well-designed randomized studies have been done to compare 1 versus 2 transplants in myeloma. So that's basically you get diagnosed, you get your induction or your initial therapy, and you either get 1 round of high-dose chemotherapy or you get 2, so 1 or 2 transplants. When it's been randomly studied on the larger group of patients altogether, there's not been shown to be a benefit. And there was a big study that the US did called the Stamina trial that recently was published. However, if you look at some of the data out of Europe, and then particularly again in our high-risk patients, there is likelihood that high-dose melphalan, giving it 2 times or tandem transplant, is beneficial in those patients. The problem is Medicare currently will only cover 1 transplant. But for many of our patients in a disease that has an average age of diagnosis in the late 60s, it's not going to be an option almost regardless.
Okay, next one, another great question. I am diagnosed with SLL. My blood is totally normal. At this point, my CBC results do not indicate CLL cells. This can make it difficult to track the progression of the SLL. What criteria are used when to begin treatment of a patient like me with SLL? Dr. Venu?
Thank you. That's a very good question. So if you don't have changes in the blood that can be monitored very closely, like in CLL, then you depend on other things, like if your lymph nodes are getting bigger. If you say that, yeah, I have increasing swelling in my neck, then we will do a CT scan. And if that is true and, need treatment, we will do that. Or, if your blood count start going down, for example, if your small lymphocytic lymphoma is filling your bone marrow, your hemoglobin may go down, you will become more anemic, your platelets may go down. That's an indication for treatment. So I think there are many other things we can monitor apart from the blood count to determine what is the most appropriate time for treatment.
Okay. Next, Dr. Hagen. There's a condition called smoldering myeloma, and some of our patients have this condition, and we don't recommend therapy. Why not? And how do you diagnose it? And when would you give those patients therapy?
Sure, it's a good question, and it's another area that's actively being investigated. Myeloma is a disease that develops over quite some time. So you can almost liken it to a colon polyp becoming a colon cancer. You start out with an entity called MGUS, where there's some of those bad plasma cells that are making a little bit of protein, but they're not causing any damage. When we get full-blown myeloma, there's lots of those cells, and they are causing damage to things like your kidneys and your bones. Smoldering myeloma is kind of right in the middle there, where we have a fair amount of bad plasma cells or cancer cells in the bone marrow, but they're not causing any damage to organs. So there's been 2 studies that have actually looked at randomized patients to get either just that drug Revlimid that I talked about or nothing. And both of them did show a progression-free survival advantage, meaning time before patients actually develop myeloma. But that kind of makes sense, right? If you're treating it, you're less likely to progress. So it hasn't really changed the standard of care. There is an ongoing study actually done by a big cooperative group called ECOG that's looking at this, now looking at 2 drugs. So again, with some of our better therapies and more better tolerated therapies in particular, like that drug I mentioned called daratumumab, I think this is still an area that's ripe for investigation. There's some thought that potentially we might be able to cure some of these patients, but we really don't know the answer to that yet, but it's an opportunity to be involved in clinical trials.
Okay, great, thank you. Next question on CLL again. I'm currently on a BTK inhibitor, and I'd obviously like a less expensive, less tedious treatment. Anything on the horizon for that? And based on your comments you made a couple of minutes ago about venetoclax, if somebody's got a great response to Ibrutinib, would this be a patient that you would consider switching to obinutuzumab and venetoclax in hopes that you can stop the therapy, Dr. Venugopal?
I think that certainly is a very good thought, but if you are already responding to Ibrutinib alone and you are tolerating it very well without side effects, then I don't think I would recommend changing it. The combination studies have been designed in such a way that you get 6 months of treatment IV, the obinutuzumab, and then you continue the pill for a year or 2 years for relapse situation. So that's the data we have. We don't have the data to say that in a patient who is responding to Ibrutinib, if you change it to venetoclax and obinutuzumab, are they going to get the same benefit? So I wouldn't do that. I wouldn't recommend that.
Okay, next for Dr. Hagen. There's been some reports over the last 5 or 6 years of patients with multiple myeloma getting acute leukemias. Some have linked it to Revlimid. So how often do patients who are taking Revlimid get a leukemia?
It's a good question, and it's definitely a question we've wondered a lot about as we've been using more and more long-term Revlimid and drugs in that class. And the data we have from the transplant studies where patients get a transplant, go on maintenance, would say that the rate of what we call secondary primary malignancy, so a new cancer that develops, is probably in the 1% to 5% range, depending on which study you look at. So it's low, and the vast majority of those tend to be skin cancers, but there are serious cancers that can develop, so things like leukemia. myelodysplastic syndrome, and even other solid tumor cancers like colon cancer. But these are not the rule, and they're more of the exception. And what I tell my patients, at least, is I say, you know, all of that is incorporated when we talk to you about the benefits of the drug. So, you know, that should be captured in things like survival analyses. It certainly is a risk, but it doesn't outweigh the benefits, in our opinion, in terms of giving the drug. But it's something you should be informed about, certainly, as you're starting a long-term maintenance program.
Okay. Next, another CLL question. CLL has invaded the lung lining. It is rare. It's probably producing pleural effusion, I would imagine. How is that treated? Regular therapy with venetoclax is working great on blood and lymph nodes, but it's not helping the lungs. Still has a lot of problems with symptoms, probably a lot of excessive coughing. I would imagine that a patient like this would have irritation of the pleural surface and would have a pleural effusion, and the therapy is working, but the effusion is not going away. So, Dr. Venugopal?
Okay, so you have CLL and you are getting a treatment, an effective treatment, and looks like all the areas are responding very well, as you said, the lymph nodes, blood, but there is one area in the lung which is not appearing to be responding to treatment. When you see that, you have to be concerned, because is it the same process there, or is it a different process? Because CLL patients can have other malignancies, so that's one thing. The second thing I would be concerned is, has CLL changed in that area? Like, as you know, CLL can sometimes change to aggressive lymphoma. We call it transformation. So in that case, the treatment is different. So in your case, if everything else is responding and the area in the lung is not, I would suggest talking to the doctor about finding out what that area represents. Ideally, it should be a biopsy, and then determine what to do about it.
Okay. One of the questions that came in on the chat, and again, people can click on the chat button and type a message and we'll get it. If CLL and multiple myeloma are related, Dr. Hagen, can an individual get myeloma if they have CLL?
So technically, the answer to that would be yes. Unfortunately, you know, we've seen patients with both of those diagnoses, but they're not really related. They both come from a similar type of cell called a lymphocyte, and they're both kind of mature cancers of those lymphocytes. Whereas, for example, immature cancers are acute leukemia, so things like acute lymphoblastic leukemia as opposed to chronic leukemia. So the short answer is yes, it's possible, but it's not a common entity, and they're not related in that fashion.
Okay, thank you. Dr. Venugopal, a patient sent in a question that suggests that they're getting Rituxan maintenance every other month for 2 years for therapy for CLL or SLL. Is this a typical therapy? What's the benefit and what are the drawbacks?
Okay, rituximab maintenance means every 2 months you give one dose for 2 years. That's the FDA approved rituximab maintenance, but that's a treatment we do in certain types of lymphomas, particularly follicular lymphoma. That's where most of the studies have shown it to benefit, because people who take maintenance rituximab stay without the disease coming back or progressing for longer time compared to people who don't take maintenance. It doesn't have any survival advantage, but it does keep the disease under control for longer time. Having said that, it's not something we routinely do in CLL or SLL, where, as I said, the benefit is mostly in follicular lymphoma and also, mantle cell lymphoma. For example, after transplant, maintenance rituximab is beneficial, but I wouldn't routinely recommend maintenance in CLL with rituximab unless it is part of a clinical trial.
Okay, thank you. Patrick Hagen, you gave some nice data on the potential benefits of transplant for patients, not only improvements in remission duration, but deeper remissions and in some cases improvement in survival. Which patient would you not recommend a transplant for?
That's a hard question. I would tell you there is no one medical problem that makes you not a transplant candidate. So there are various kind of scoring systems that have been developed for transplant risk for autologous. So that's, again, when you're getting your own cells. But they don't generally hold up as well. There are some patients with multiple medical problems who maybe can't tolerate 3 drugs or are barely getting by on 2 drugs for myeloma. Those are not ideal patients for transplant. But, patients often get stronger after they start their therapy. So if you're able to go to and from your clinic appointments and you're tolerating your therapy well, almost regardless of what medical problems you have, you should at least come and be evaluated. I think that's the take-home point. What we see a lot is patients who were never sent, and then they get sent when the disease comes back, and then it's tougher to get them in remission. So there is no hard and fast rule. We just would really encourage everybody, no matter where you are, to at least see a transplant physician and know whether or not it can be offered to you.
What about if somebody is on renal dialysis because of kidney failure from the multiple myeloma?
No, actually, it's even in those patients that it can actually be easier to get those patients through a transplant than someone who has chronic kidney disease and isn't on dialysis in some ways. So no, those patients are still transplant candidates, and sometimes in rare cases can even be offered a kidney transplant. So that, again, there's really no one medical problem. I would say if you're up and active and can take care of yourself and make your appointments and stay on your therapy, you're a transplant candidate and should be evaluated.
Dr. Venugopal, as we all know, not every patient who comes through the door, in fact, probably only a minority initially, come through the door, and we recommend therapy for them. In other words, there's the watch and wait plan for patients with CLL as well as some other types of lymphomas. Are there patients that come through the door that are otherwise good risk patients, don't have a lot of disease, have a good performance status? Are there any of those patients that we should consider taking to therapy earlier than another group of patients? I guess what I'm trying to ask are there prognostic factors that might lead you to treat somebody earlier versus later before they get into problems?
Good question. I mean, this is something that has been researched over and again, because as you can understand, you are told that you have a cancer, and I might even have told you I have an early stage cancer, and then I say, well, you don't need treatment. We will just watch you. Doesn't make much of a sense when you hear that. But the fact is that treating even patients who have the so-called low-risk disease, including the factors which I mentioned, the more recent prognostic factors, including molecular characteristics, you identify the low-risk CLL and treat them, the overall survival doesn't make a difference between the treated patients versus the observed patients. So that's the reason why we still consider those patients are best observed without treatment.
Okay, next for Dr. Hagen, you mentioned that there's an evolution of disease, but kind of a similar question. But patients don't always start off with frank multiple myeloma. They have a condition called MGUS, monoclonal gammopathy of uncertain significance, or a smoldering myeloma. And if you're diagnosed with an MGUS or a smoldering myeloma and your doctor doesn't plan to treat you, what type of follow-up or what type of testing should you be undergoing, and how often?
So we'll start with MGUS because they're a little bit different entities. So a patient with MGUS, I would say, typically needs blood work and follow-up every 6 months. There are some features of even MGUS that might make somebody more or less at risk of progressing ultimately to myeloma. So there are rare patients you can get away with annual visits. Some patients may need even more frequent than every 6 months. But I think roughly about every 6 months is reasonable. With smoldering myeloma, again, the risk of progression is about 5% per year to myeloma, meaning 1 in 20 patients will progress. So these are patients that probably need to be having their blood work checked about every 3 months, I would argue. Again, there are some features that might make you more or less at high risk of progression, so maybe that's altered a little bit in one way or another. But smoldering myeloma patients need to be monitored more frequently, because what we don't want to see happen is have those patients come into our emergency rooms with kidney failure and broken bones and in tough shape. So, and those are patients, as I mentioned earlier, I would highly encourage to seek out clinical trial opportunities.
Okay. We have both one of the pre-meeting questions and one that just came through on the chat line. And it's for probably for both of you, but we'll start with Dr. Venugopal. First, are there any trigger foods that aggravate CLL? And then are there any dietary or lifestyle effort that impact disease progression? For example, there was a very poorly done study on green tea extract. Any further information on that compound? Organic versus non-organic food, and frequent flying with increased radiation. Nobody's flying these days, but we hope to again sometime soon. But any dietary or lifestyle things that can aggravate CLL, and then Patrick can answer it for a myeloma.
Okay, starting with the first part of it, that is, are there any trigger food that can aggravate CLL? Not to my knowledge. I don't know of any specific food items which can worsen CLL by itself, by the food itself. No, not to my knowledge. And what was the second part, Pat?
About dietary or lifestyle efforts, green tea, organic, non-organic foods.
Got it. Okay, so I think this question comes very often from the patients, and my usual answer is this. These are chronic diseases. These are diseases where the body's immune system has a lot to do with their stability and loss of, control. So therefore, if you keep your health well, so in other words, a good, balanced, nutritious diet, and keep your physical activity and, exercise, which will keep your immune system intact, that certainly will help to some extent in maintaining a low level of progression. That's the best advice I can give. Now, in terms of green tea, I'm sure you know that there's been a lot of work done. I think Dr. Neil Kay at Mayo Clinic almost spent all his lifetime doing that. I don't think we have any scientific data to say that, yeah, if you take this many grams of green tea every day for the next 1 year, your risk of progression of CLL is reduced by 20%. I don't have that data. Many of my patients do take the amounts they can tolerate, not exactly the ones that has been described. So I am not recommending that, but people do take it. Some people believe it. And I don't have a scientific data based on which I can say that it will help.
Okay, Patrick, for myeloma, answer the same questions.
Yeah, I would kind of echo some of the similar sentiments. Most of our drugs that we use in clinical practice, antibiotics, cancer therapeutics, were developed based on our knowledge of natural substances in the environment. So there is data, lab data, that says green tea extracts have some activity against cancer to some level, but it's never been proven in clinical trials, and probably the amount you would need to take would be astronomical. So I would say as of now, no. And I would echo, what was just said, I tell my patients, it's important that you're living the healthiest lifestyle, giving yourself the best ability to fight your cancer. So a general healthy lifestyle, being active, kind of those boring things are probably the most important things.
Okay, next question, again for both of you. I have CLL or I have multiple myeloma. What are the chances that my children or grandchildren are going to get it, or sisters or brothers? And what can they do? They don't have the disease. What can they do to prevent themselves down the line from getting these diseases? Since I asked Dr. Venugopal that one first, I'm going to go back to you right away, Patrick, and answer this one. And you'll have a chance to think about
it. So there are, if you get enough of any disease, you're going to see it cluster in families randomly. So I definitely have patients who have siblings or parents who've had multiple myeloma. With that said, it's not a disease that runs in families, and there are case series of when a mutation happens, it can be in one family, but not something that runs through generations. So I think the challenge is that these are common diseases. So multiple myeloma is the second commonest hematological malignancy after large cell lymphoma. So you just look at the raw numbers. If we make it into our 50s and 60s and 70s, the chance that you might see 2 cases in a family starts to go up. So I tell all my patients that no, you don't need to worry that your loved ones, your kids, your parents are going to get this. It's a disease, unfortunately, of bad luck and old age in general.
Dr. V.
Yeah, I echo exactly the same Dr. Hagen's comments. That is, there is nothing at this point to indicate that there is a hereditary transmission of the disease from your parents or that you can give it to your kids. Just like in breast cancer, for example, they can calculate and tell you the risk, but that is not available for, CLL at this time. The only data we have is these registry studies from Sweden. I used to show that in meetings like this, where when they look at large population, they do see that families where you have a first degree relative has CLL, they have a much higher risk of developing the same disease. But when you say higher risk, it's like 2 times or 2.5 times the risk that a otherwise healthy person has. So that's the best data we have. So in other words, if somebody asks me that question, I will say there is nothing indicating a transmission. And just as Dr. Hagen said, because it's such a common disease, you can have by coincidence more than one person in one family.
Okay, now that you're warmed up, we have a very intensive question. Based on the fact that we have all used criteria for diagnosing and treating patients with CLL and myeloma, are those diagnostic criteria that we use to decide treatment still relevant today in the light of the ability of some of these treatments to get patients into an undetectable minimal residual disease state? Dr. Venugopal.
That's a great question. Absolutely. You're right. I think people are warming up and the standard of question is going up and up. Okay, very good. So I think, I showed you some slides about diagnosis. How do I diagnose CLL? The basic diagnosis of CLL, to say this patient has chronic lymphocytic leukemia, is still the same we have been using all along. That is, a flow cytometry is probably the most important test, which will tell you this patient has CLL versus this patient has a follicular lymphoma or a mantle cell lymphoma. So that part is clear. On the other hand, we have much more information now. We can define that CLL in many different ways: high risk, low risk, likely to respond to this drug, not likely to respond to the other drug. So there are a lot of qualifications we can assign to a particular patient's disease. But the diagnosis part, I think we are still depending on the same things we did in the past, and that is still valid. That's the best answer I can give, Pat.
Dr. Hagen.
Yeah, I think all the same tenets apply in myeloma. The one thing that has changed, and I would say we do reassess this every 3 to 5 years about, the quote unquote experts get together and sit down in a room and hash this stuff out. And recently in myeloma, the one thing that did change is, for example, we realized that patients who had so many cancer cells in their bone marrow, and that number is 60%, that those patients were so highly likely to progress to myeloma that the diagnostic criteria did change. So in myeloma is a different disease than CLL though. So these things are always being reevaluated, and they should be. And in terms of the MRD piece of the question, that's actively being studied. So we think that patients who can achieve MRD negative remission and sustain it in myeloma may very well be able to come off therapy. And similar things are being studied in CLL, has been mentioned previously.
Okay, we're coming close to the end. I have 2 more questions. You'll be relieved to hear. First, Dr. Venugopal, and this is again a question for both of you. Are diagnostic and prognostic tests repeated as time and the disease progressive? If so, when? And if not, why not, since these diseases can mutate over time?
Well, the typical follow-up in a patient with CLL would be, of course, depending on the risk factors. Some patients I see them once in 6 months, some patients I see once a year, and some of them even once in 3 months. It depends on the risk factors. And in terms of repeating the test, I don't routinely repeat any test. In CLL, as one of the participants pointed out earlier, it is fairly easy to monitor the disease because of the blood counts and also the other findings like lymph node enlargement. It is much easier to follow. But now, at any point, if I see that the disease is progressing, at that time, especially if there is a decision for treatment, if I'm planning to treatment or planning to recommend treatment, then of course I'll be repeating the studies, including the tests which I mentioned, FISH, for example. I will do that, including chromosome abnormalities, because they can change. If you were diagnosed with CLL 5 years back and you are not treated and now you need treatment, certainly you should repeat those molecular tests because things could evolve over time and may determine the appropriateness of the treatment at this time, which was not probably there when you were originally diagnosed.
Patrick.
Yeah, it's again similar sentiments in myeloma, and I mentioned this in my talk as well. Is myeloma is a schizophrenic disease. It's all over the place when it relapses. So, I think it's critically important that this assessment is repeated, the bone marrow in particular, because it sets the expectations of how patients are going to do with therapy. And I think that that's really important for patients, and it gives us other information. So, for example, unlike in CLL and myeloma, we do high-dose melphalan transplant, and that risk of things like myelodysplastic syndrome and bone marrow failures is there. So as the patient goes on their lines of therapy in myeloma, I also want to know how healthy is the bone marrow. Are there any other problems that I need to deal with as I'm debating what therapy patients might go on to? And then often, we're offering patients clinical trials at those points too. And so they can be required frequently by trials, but we would be doing them, in my opinion, as a standard of care, whether or not a patient is on or off study.
Okay. One last question, but before we ask this one, there are a couple other questions that people have sent in. One on CAR T cells, one on non-Hodgkin's lymphomas, and I would just like to remind everybody that our next session will be a session on CAR T cells and non-Hodgkin's lymphomas. The CAR T cells by Dr. Hussain, and the non-Hodgkin's lymphomas by Dr. Smith. Dr. Hussain is also from Loyola. Dr. Smith is from the University of Chicago. So join us for those, and you'll get much more of a detailed response to your question beyond what you heard today from both Dr. Venugopal and Dr. Hagen. So the last one will come as no surprise. We are in a pandemic, and patients have cancer, and patients are getting treated. And it can be a very isolating time for patients and for families. You have a loved one that is getting treatment, and you're barred at the door. So can each of you then address why that's happening, why it's important for cancer patients to be particularly mindful of the COVID virus, and in particular, what family members should do in living with and being cared for by and caring for cancer patients? What do they have to do? How to ultimately minimize the risk, and what are the risks for patients with cancer in getting COVID? And I'll let Dr. Hagen, you could be first, and then Dr. Venugopal.
This is a question I have this conversation almost every single day. So, for myeloma, it's a disease of the immune system, and the number one cause of death in myeloma is infection. And unfortunately, there has been some data recently published in COVID that our myeloma patients are at particular high risk, even amongst the hematological malignancies. And that's not a big surprise. So I tell my patients that, it's better to be conservative. And I'm honest, I have a more conservative outlook on COVID and isolation. So I think that's part of the conversation. But anything we can do to protect you and protect your family is critical. And we also tell them that it is one bunch. So, your household is the risk group. So you need to keep that in mind. So that's my general stance. And there's no right answer here. I just think it's an important dialogue you need to have with your doctor so you understand what we know and what we don't know.
Will you recommend when the vaccines are available that patients get these?
Absolutely. So there is good data in myeloma, even in patients who go through transplants, that they can have good enough responses where they should be vaccinated, and they should be at the top of the list. Not myeloma, but hematological malignancies, I would say in general.
Okay, Dr. Venugopal.
Exactly same. I tell them, wear a mask if you have to go out, wash your hands, and certainly try to keep at least 6 feet when you are immunosuppressed. And of course, if you are taking treatment for cancer, that 6 feet may not be even enough. So I think those are the things I talk. Basically, the same principles many of us know, and they have to be emphasized, because I personally don't feel that if people are following all these principles, the patients with CLL are not particularly at higher risk of getting it. But if they get it, certainly the risk of getting into trouble is higher. That's what I tell them.
Yeah,
Right.
absolutely.
And we heard today from the head of the CDC that said basically, depending on how effective the vaccines are, the masks may actually still be much more effective than a vaccine down the line. So it truly has changed the outlook for countries. We won't mention the US, but other countries like Japan and Taiwan and South Korea and certain states, including Vermont, where everybody has to wear a mask if you go out in public or you're shamed. And that's why their incidence is very low as well. So I definitely reiterate the notion, masks really can save lives. And I also agree that if a patient with a hematologic malignancy, a blood cancer, gets COVID, they are in deep trouble. So the goal is an ounce of prevention is worth a pound of cure. So it is 9:01. We said we would finish at 9 o'clock, and we did. I would like to thank our two speakers today. You guys did a great job, and you did a great job answering the questions. Truth be known, we did get a lot of questions, but I also in seeing patients every day, hear a bunch of questions that I slipped in myself, and you did a great job in answering them. I would have answered pretty much all of them the same, but I really appreciate you spending your evening with us. Both of you are still at work. Congratulations for working so hard. And it just shows your commitment, not just to your own patients and your own institutions, but also to cancer patients at large, especially those with blood cancer. So my heart goes out to you for staying late at work, and you have my permission to go home now. And Carrie, thank you for setting this up, and we look forward to everybody joining us again in 2 weeks.
Thank you. And Dr. Stiff, we want to thank you as well. The recording will be sent as soon as it's available, and please complete our evaluation. We will be sending that out probably tomorrow morning. Thank you again, and we hope that you'll join us for another one of our sessions. We have one on September 30th and one on October 14th, as Dr. Stiff pointed out earlier. Thank you, everyone, and good evening. Have a good night.
Good night.
Thanks, everyone. Bye-bye.
Bye-bye.